take your seats. Professor Loretta Ferris, Vice Principal Academic, members of the University of Pretoria Executive, Professor Ute Feucht, members of the Faculty Executive, including school chairs, distinguished guests, colleagues, students. I'm Tiaan de Jager, Dean of the Faculty of Health Sciences here at the University of Pretoria. This evening's inaugural address will be presented by Professor Ute Feucht and will focus on the fetal and early childhood factors influencing lifelong health. Please allow me to welcome Professor Loretta Ferris, our Vice Principal, to introduce Professor Ute Feucht. Professor Ferris is currently the Vice Principal Academic at the University of Pretoria. Prior to working as a law professor at the UP Faculty of Law, having rejoined UP in February 2022, she was Deputy Vice-Chancellor Transformation, Student Affairs and Social Responsiveness at the University of Cape Town. She holds numerous leadership roles at UCT, including the Director of the Institute of Marine and Environmental Law, as well as Director of Research, both roles at the Faculty of Law. Professor Ferris has 28 years of experience as an established scholar with international standing and commendable scholarly work, with 8 years of experience at the senior management level. She has experience in teaching and learning through her participation in multiple academic committees, including the UCT Teaching and Learning, Language and Social Responsiveness Committees. From 2024 to 29, Professor Ferris was Associate Professor of Law and Program Manager of the International Trade and Investment Law in Africa program at the University of Pretoria. Prior to that, she was involved in several roles at the Washington College of Law, American University, Washington, D.C. in the United States. Professor Ferris serves on the board of BioWatch and chairs the board of Natural Justice, both civil society organizations with a strong focus on environmental justice. Professor Loretta Ferris.
Good evening and welcome to everyone here, as well as those of you that are joining us online this evening. On behalf of the Senate of this university, it is my privilege to welcome all of you to this inaugural lecture of Professor Ute Feucht of the Department of Pediatrics in the Faculty of Health Sciences at the University of Pretoria. I would like to extend a special word of welcome to Professor Feucht herself, her members of her family, and in particular her husband Bernd, their children Theo and Michelle, her parents Professor Fritz and Ms. Tusi Han, and just to note that Professor Han was the Dean of Sciences at my alma mater, University of Stellenbosch, until his retirement, and thereafter co-founded the African Institute of Mathematical Sciences based in Muizenberg. Also, a special word of welcome to any of my colleagues in the executive. I haven't seen anyone, but in case they are here. The Dean of the Faculty of Health Sciences, Professor Tiaan de Jager, as well as some of his colleagues in the faculty, including Professor Vanessa Steenkamp and Prof. Priya Somapillay. I also noted the Dean of the Faculty of EBIT here this evening. Good evening, Prof. Feinand Steyn. Then I would like to acknowledge the current and previous pediatric academic heads at Steve Biko Academic Hospital, Prof. Isel Smits and Prof. Dankwart Wittenberg, as well as the pediatric head at Kalafong Provincial Tertiary Hospital, Professor Teens Avenant. Also, I'd like to acknowledge the presence of Dr. Leslie Bamford, who's the Acting Chief Director of Maternal and Child Health at the National Department of Health, Mr. Motomomi Pitse, who's the Acting Chief Director for District Health Services at Gauteng Department of Health, as well as Mr. Modise Makudu, who's the Acting Chief Director at the Tshwane District Health Services. And then finally, Dr. Shufang Huo, who is the Chief of Health and Nutrition at UNICEF. Good evening, welcome every other member of the senior management who may be here. And then to all of Uta's friends, her mentors, her peers, her colleagues, everyone who has helped to shape her career and who has offered up their time to get her to this moment in her life. And last but not least, all of her students as well as prospective students. It's the first time that I have to welcome prospective students. It's amazing that they have not yet been supervised by you, but they're already in the audience. So we're delighted that we can share this occasion with each and every one of you, whether you're here tonight or at your house or at your office. But before we ask Professor Feucht to take the stage, I would like to formally introduce her to you. And I hope that you're going to have enough water and that you're sitting comfortably because it's a long CV. So after high school years in Stellenbosch, she completed her undergraduate medical training at the University of Stellenbosch. But then her postgraduate pediatric studies was completed here at the University of Pretoria, and then she went back to Stellenbosch for her PhD. In 2023, she received her recognition as a subspecialist community pediatrician. Professor Feucht started as a hospital-based pediatrician and clinical manager of a very large and rapidly expanding public sector pediatric antiretroviral treatment site in Pretoria. Her initial clinical work and research focused on pediatric HIV disease and the practical implementation issues and management of pediatric HIV antiretroviral treatment in South Africa. She's been involved in South Africa's HIV epidemic since the start of the ART program and has observed, participated in, and learned much from its evolution over the past 2 decades. Her interest, however, has since expanded to a much wider focus on overall child health issues and policies. Her research addresses broad issues of child health with a focus on PMTCT, pediatric HIV treatment and care, childhood nutrition and growth, and improving childhood morbidity and mortality. Her current focus is on fetal growth restrictions and the implications thereof on childhood growth. Professor Feucht also works on the development of data systems to improve clinical care and monitoring of health outcomes. Her work strongly drives the Survive, Thrive, Transform agenda with the ultimate goal to improve the outcomes of children and their families within the communities that she works within in South Africa as well as beyond South Africa's borders. Over her many years of involvement in maternal health and child health, she's gleaned a wealth of clinical, scientific, strategic, operational, and management expertise. She's built significant strategic trust relationships with key stakeholders and has a long track record of leading by example, delivering results, ensuring good communication, and a steadfast dedication to improving outcomes. At present, Professor Feucht wears many hats. She's an active member of the Department of Pediatrics here at the University of Pretoria. She's also the Tshwane District Clinical Specialist Team Pediatrician, part of a multidisciplinary team of specialist doctors and nurses tasked with improving maternal and child health outcomes. And then if that's not enough, she's the director of the University of Pretoria Research Center for Maternal, Fetal, Newborn and Child Healthcare Strategies, which is based at Calafon. She's also the Deputy Director for the Maternal and Infant Healthcare Strategies Unit for the South African Medical Research Council. And then, of course, like most other academics, she's a postgraduate and research supervisor, and she has supervised 13 master's and PhD students to completion, 3 of whom has graduated this year in 2024, and she currently has 5 masters, 4 doctoral students, and 4 prospective doctoral students in the protocol development phase, some of whom are in attendance this evening. And then she works extensively with colleagues in the provincial and national departments of health, in think tanks, and on guidelines and protocol development. Through these different roles, she's responsible for the implementation of research projects and multi-stakeholder collaboration, providing education, research supervision, providing and overseeing clinical care, the management and mentorship of staff and students, their scientific outputs, as well as the enormous associated grant funding allocations. So she is a busy woman. But of course, as with all other women, she still finds time for other things in her spare time, such as writing. And so she's published 57 peer-reviewed scientific journal articles, as well as other popular journal publications. She also serves on the editorial board of South African Journal of Child Health and is a reviewer for many prominent South African medical journals. She's recognized for excellence in all she does, and she's received a number of academic and service awards, and currently holds a C2 NRF rating as an established researcher. But if you ask her what she is, she will tell you that ultimately she is a devoted wife, a mother, a proud daughter, a gardener, and a keen camper. This evening, we have the honor of witnessing Professor Feucht's inaugural address titled The First 1,000 Days of Life, Fetal and Early Childhood Factors Influencing Lifelong Health. In a daily working environment, Professor Feucht is directly exposed to an environment in which suboptimal child growth and development are rife, in spite of the United Nations Sustainable Development Agenda and the goals for the well-being of children. So tonight she will give us an overview of her research, focusing on the first 1,000 days of life from conception to the age of 2 years. And this period is known to shape the trajectory of lifelong health and well-being. She will share with us her findings on the interconnected risk factors for suboptimal fetal growth and postnatal well-being, and the impact of maternal HIV infection on her offspring, not her offspring, but the offspring of her mother, even when the children themselves remain uninfected. Professor Feucht will explain the pivotal role of placental function on fetal development and the detrimental effects of fetal growth restriction, explaining how the first 1,000 days are critical to unlocking each child's genetic potential and contributing towards lifelong health. She will also explain the intricate interplay between HIV exposure, placental insufficiency, and socioeconomic deprivation as compounding challenges faced by South African children. Then in closing, she will tell us a little bit about her future research on fetal growth restriction and how the research aligns with the overarching objectives of sustainable development, especially regarding the well-being of vulnerable child population. We look forward to your lecture this evening, and over to you, Professor.
Good evening, ladies and gentlemen, and to all the special guests, Prof. Ferris, thank you, and Prof. De Jager and the Deputy Deans, Prof. Smits and Avenant, who are my pediatric HODs, and all my colleagues from pediatrics and from the district health services. And then, of course, to my husband, Bernd, and my 2 children. I'm very happy that they are here. Because actually CEO is a Marty now, so he's here on his spring break, so I'm very happy that he's here. And then to my parents, who I am exceptionally happy that they are here. My sister is online, so she is in Windhoek. She's an anaesthetist, so greetings to her as well, and to all the other people who are online. Thank you so much for attending tonight. So usually when we meet in person, and we start communicating with this person, we link up with them on a human level. So instinctively, we connect with them. We ask them, how are you? And then we connect with them, we connect with their brains, and we connect with their hearts, their emotions, and the social cues that they give us. So as humans, we've sort of made terminology for this, so abbreviations like IQ and EQ, very well known. SQ is the social quotient. And tonight I'm going to tell you about my tongue-in-the-cheek PQ. Okay, so if you don't know what the PQ is, it's because I made it up. Okay, so that is the placental quotient. So, how are you today, and how good was your placenta? And I put a little drawing there so that the non-medical people don't run out of the room because I put a real placenta there. So probably you've never thought of your placenta. But the irony is that this organ of ours that gets discarded after birth is intricately linked to whether or not you, as you are sitting here tonight, might be struggling with hypertension or obesity or other chronic conditions. So tonight I will be telling you how important this placental function is. So second try, if you are now not so sure how good your placenta was, do you at least know what your birth weight was? Because you will see throughout this presentation that this is also a really important metric. So as this is my inaugural lecture, I will give you a little brief history of my own journey before we can get into the more technical part of this lecture. So I was born here in Pretoria. My birth weight was around 3 kilos. That's how far I could get out of my mom. And what do I know about my placenta? I can tell you nothing. Okay. I was born by elective cesarean section, and with my birthday being the 30th of December, I always thought that that was a really stupid day to do an elective cesarean section on. And as a child, I was always very grumpy about having this birthday in the second last day of the year. And when I asked my mom, she said, no, she thinks the obstetrician still wanted his money in the old year. So here I am with my birthday. So I grew up, I started my schooling here in Pretoria, and then we moved to Stellenbosch in 1981, where I continued my schooling, and then went to medical school. And this is my graduation photo from my medical studies together with my parents. The same year, I married my husband, so 1995, a big year for us. 1996, I started here in California. I started my internship, and when I walk into California, I really sometimes think I'm part of the furniture there now. In 2003, I became a pediatrician, and I registered as a pediatrician, and I stayed on at California as a registered pediatrician, and as you've already heard, I then actually started with the work in the antiretroviral treatment clinic, because in the year 2004, the 1st of April, we started with the ART rollout, and California was one of the first 5 hospitals in Gauteng that started the ART program. And I was in charge of that pediatric clinic at that stage. 2004 was also important because I became a mom, and our daughter was then born in 2007. I continued working at California and then moved into the district health services in the year 2012. And I still maintained my joint appointment and with the University of Pretoria and the Gauteng Department of Health. In 2015, if it's going to show me, yes, there we are. I then graduated with my PhD, and that obviously was a big milestone. And although I did my PhD at Stellenbosch University, I was still working here in the California area at that stage. Okay, this thing is... Okay, so let me tell you about my PhD. It was my journey into science and into community pediatrics. And I really want to thank my mentor, Prof. Mariana Creer, who is joining us virtually today, for guiding me on this road. My topic was improving the care of HIV-infected children and HIV-affected children during those early implementation years of the large-scale antiretroviral therapy program in South Africa. In my dedication that I wrote for my PhD at that stage, actually when I looked at it again, I thought this is just as true today as it was when I wrote this in 2015. So my dedication was to my parents, Fritz and Tusihane, for always supporting me and teaching me that science should always serve humankind and never the opposite. To my husband, Bernd, for always standing by me in the good and the bad and the very busy times. And to my happy and healthy children, Theo and Michelle, and to all the children of this beautiful country, many of whom are much less fortunate than my own. My chapters in the dissertation were on HIV testing in children, on missed opportunities for care, on viral resistance, and on growth in children. So after my PhD, the first grant that I received as a principal investigator was the CIPHER grant from the International AIDS Society, together with Professor Teresa Rousseau, who's also here from the University of Pretoria. So initially, HIV transmission in children was our major concern, because children became infected with the virus, and especially because HIV has been such a prevalent condition in our country. This was a huge clinical concern in the pediatric services. So in the last few years, the HIV prevalence in pregnant mothers in our country has been hovering around 30%. So children living with HIV, especially if they were untreated, as we saw initially in the epidemic, are known to have major growth and development deficiency. But once we started getting a handle onto reducing the HIV transmission to children, we actually started also noticing that there were associations between maternal HIV infection and all the antiretrovirals that the mothers were on, and the growth and development of the children, even if the children were HIV uninfected. And for this, the underlying mechanism was and is actually not fully understood, because the children are actually not acquiring the HIV from the mothers, but they are still presenting with growth and development deficiency. We therefore embarked on the Siakula cohort study here in Pretoria, and we anchored the study at the Research Center for Maternal, Fetal, Newborn and Child Healthcare Strategies, which was then under the directorship of Prof. Bob Patterson, who then became my next academic mentor, and with a very, very special greeting to him in the online audience tonight. So the hypothesis of Siakula was that the changes in the intrauterine milieu in HIV-exposed and infected children reprograms the infant's pathways in terms of their growth, their cognitive development, and the development of their immune system. To be successful, the study needed to span the continuum of mother, fetus, and child, and take into account the multifactorial nature of fetal and early growth and development. We therefore formed very strong collaborations between members of various departments, namely obstetrics, pediatrics, family medicine, nutrition, and immunology. 5 PhD students also joined the study, from obstetrics, 2 from nutrition, and 2 from immunology. And we don't have time to go into the Siakula results in great detail tonight, but in summary, we found that these HIV-exposed and infected children were smaller at birth, that had suboptimal subsequent growth, and with particular risk in the complementary feeding phase, with inappropriate infant feeding practices and lower breastfeeding rates. We were also particularly interested in whether the breast milk composition was maybe suboptimal in the women living with HIV, but there was no measured differences in the breast milk macro and micronutrients between the 2 groups. So please meet the Siakula team. You can see that this is our collaborative study. Okay, so through this work, The first 1,000 days became entrenched as one of the main themes at the research center, with a very strong obstetric and pediatric component, with nutrition and basic sciences, especially immunology, forming strong additional components of the team. In December 2017, Prof. Pattinson retired and handed over the directorship of the research center to me. So what is this concept of the first 1,000 days? It is the time from conception to the second birthday of a child. It is the period of tremendous potential and enormous vulnerability. About 80% of the baby's brain growth happens in these first 1,000 days. So in this period, the foundations are laid for optimal health, growth, and neurodevelopment across the lifespan, not only in that short period. The other thing that's really important to note is that the well-being of the mother and the child are closely linked during this period. Interestingly, non-communicable diseases later in life are linked to this period of the first 1,000 days, according to the Feucht hypothesis, which is the hypothesis of the developmental origin of health and disease. According to this hypothesis, epigenetic adaptations are made to the fetal or neonatal DNA in response to environmental influences. It further explains that the body responds to the environment and makes genetic changes, so predictive adaptations, in anticipation of a presumed future environment. Which brings us to the topic of fetal growth restriction. Many maternal factors potentially influence fetal growth in the South African setting. These include, as I've already noted, maternal HIV infection, but there are many others: maternal hypertension, demographic factors like the mother's age, obstetric factors like how many babies she's already had previously, socioeconomic factors, substance use, use of medications, infections and other maternal diseases, maternal undernutrition, maternal overnutrition, including overweight and obesity, and maternal diabetes mellitus. And then there are also placental and fetal factors, which just really shows you the complexity of this field. The consequences of fetal growth restriction range from stillbirth, in the extreme cases, to neonatal death and perinatal morbidities, to child growth disturbances, and as already alluded to non-communicable diseases later in life, as per the Feucht hypothesis. So how do we identify growth-restricted babies? One would think it is an easy task at the time of birth, but how do we assess the genetic growth potential of a fetus or a child? Was this baby destined to be a big baby or a small baby? So you can gather that this is actually quite impossible to do. So examining the baby at birth and looking for wasting is a good start, but only in severe cases is this usually obvious. As you can see, these two moms would be in a labor ward, one with a very well-fed baby and the other one with a growth-restricted baby, and this is not even clinically noticed in many ways. So because of this, we use proxies. And this includes classification into low birth weight, which is a birth weight of less than 2.5 kilograms. But you can easily understand that the usefulness of this parameter is connected to whether the baby was actually born at term or was born preterm. And growth-restricted babies who weigh more than 2.5 kilos are missed through this approach. Additionally, we can use SGA, or small for gestational age, as a proxy, which is a birth weight of less than the 10th percentile as per gestational age and sex. And while this is a potentially useful parameter, the drawbacks are that babies need to be plotted on growth charts at the time of birth in order to make this assessment. And furthermore, because 10% of normal babies, per definition, would fall under the 10th percentile. This means genetically small babies also get flagged, despite actually this being the normal size for this little baby. So now let's look at an example of two babies, both born at 40 weeks. So which of these babies do you think has got fetal growth restriction? The orange dot on the growth chart is for a baby with a birth weight of 3 kilograms, which is above the 10th percentile, while the blue dot is for a baby with a birth weight of 2.7 kilograms, which falls below the 10th centile. So the question feels like a no-brainer, doesn't it? But look at this. See how wrong we can be. If we had meticulously followed and plotted these two babies during pregnancy, when they were still fetuses, we would have identified that the blue fetus was simply a small fetus, happily growing along its percentile, while the orange fetus has got late growth deceleration and low fetal growth restriction. This is a reminder that in utero growth and birth weight don't always tell the same story. And while we often use small for gestational age as a proxy, we should always keep in mind that it is, at best, an imperfect proxy. So summarizing this, there are those fetuses that are small for gestational age only, per definition, those who have fetal growth restriction only, and then without obviously being small, and then there's the group with the overlap, being small babies who are also growth restricted and who are at particular risk of poor outcomes. So let's revisit facts about fetal nutrition to aid us in the bigger understanding of this topic. And it's a reminder to all of us that we actually all started very small, as a fertilized egg. In the first few weeks of gestation, the fetal nutrition occurs through diffusion. With damage, if there's any damage that occurs at that stage, this usually results in a miscarriage. By mid-pregnancy, the nutrition changes to placental nutrition, with placentation completed at about 16 to 20 weeks. So at 20 weeks, when we are like halfway through the pregnancy, the fetus weighs around 350 grams. The placental size is greatly determined by the uteroplacental blood flow, while the fetal size is determined to a very large degree by the placental size. Okay. By late pregnancy, the placental nutrition is now crucial to actually supply nutrients for growth, in addition to supplying oxygen. So placental size and uteroplacental blood flow are crucial for determining the fetal size. May I remind you that I initially asked you about how well your placenta functioned and how amazing it is that we actually have no clue about this in our own lives. So placental damage leads to vascular damage, and this can be detected by Doppler. So let us have a look at what fetal growth curves look like. At first glance, it looks like almost a straight line from 24 to 40 weeks in pregnancy, with boys and girls almost equal in size. But on a more intensive scrutiny, one sees that actually it is a bit more S-shaped, albeit a flat S-shape. So to help us better understand this, let us look at the expected weight gain per week, which looks like this. And then it becomes obvious that actually there is growth deceleration of the fetus at the end of the pregnancy. If you ever wondered why normal pregnancies last around 40 weeks, this is one of the main reasons. Human placentas cannot forever support the rapid fetal growth. And there comes a time of placental failure, and we better be born before that time of placental failure. So what happens to this growth after birth? So this is the same fetal growth curve, but now with the early infant growth curve added to it. So the time of birth is of extremely great importance, being the time of transition from the intrauterine to the extrauterine environment. Initially, there's an interruption of the growth continuum, which, with some weight loss being normal in the first few days after birth, before the weight gain then accelerates again, and as we can see on this graph, with the differentiation between boys and girls now becoming evident in terms of their size. If the fetus has fetal growth restriction due to placental insufficiency, like the yellow and the red lines here on this graph, one of the big questions is whether there is catch-up growth after birth once now we have improved nutrition in place. So obviously this will then have long-term consequences for growth and size of this individual. But additionally, we also know that growth restriction greatly increases the risk of mortality, as stillbirths, neonatal deaths, and child deaths. So this is really important in terms of our mortality agenda as well. So turning our attention to stillbirths, especially antepartum stillbirths, which means that the fetus actually died before the time of delivery. And let me tell you why I, as a pediatrician, became interested in them. Stillbirths are very common. In our country, we have twice the number of stillbirths compared to neonatal deaths. Globally, 98% of stillbirths occur in low and middle income countries, and up to 50% are thought to be due to fetal growth restriction. And unexpectedly, the majority of these mothers are clinically normal. That is, the pregnancy is deemed to be a low-risk pregnancy. In South Africa, we have done mortality auditing in our public sector health facilities for many years now. And from this, we know that the majority of stillbirths are mostly antenatal and not intrapartum. So it's not linked to the care in quality of care the mother receives during the time of delivery. These stillbirths also occur mainly in apparently low-risk pregnancies, and they are coded as unexplained stillbirths. Now, this seems counterintuitive, that women with high-risk pregnancy is not at higher risk of having a stillbirth? And the answer is yes. Yes, they are. But in absolute numbers, if we now look at all the women in South Africa who are pregnant in a year, in absolute numbers, women with low-risk pregnancies have more stillbirths than women with high-risk pregnancies, as the former greatly outnumber the latter. The stillbirth rate, that is the risk of an individual mother of actually having a stillbirth, is much higher in a high-risk pregnancy. Which brings us to three main questions. Who are these high-risk fetuses in these low-risk mothers? Is it possible to identify them? And why on earth do we have so many of them in the South African setting? Okay, reminding that we have twice the number of stillbirths than what we have neonatal deaths. So let's start with the question on whether we can identify them better. What is currently routinely happening at antenatal care is history taking and symphysis fundal height measurements and then plotting on the antenatal chart. This is, however, fraught with inaccuracies. So what about ultrasound? Would availability of ultrasound solve this problem for us? Now, firstly, availability is an issue, especially at primary health care level, where most of the women with low-risk pregnancies actually receive their antenatal care. Secondly, ultrasound measures size only, and with the definition of the expected fetal weight of less than the 10th percentile used for fetal growth restriction, we've already seen that this is potentially problematic because it would also flag the genetically small baby. And to determine fetal growth, we would need to repeated ultrasound scans and meticulous plotting of the subsequent measurements in order to identify the fetus with fetal growth restricted, just as represented by the fetus with the green dots on this chart. Which brings us to the question, can we use Doppler as a functional test for placental function and thereby identify fetuses with fetal growth restriction? What you see on this picture is the blood flow in the umbilical cord, which connects the fetus to the placenta. Is it possible using Doppler? It is possible using Doppler to obtain the waveform of the fetal blood flow through the umbilical artery and other arteries, but for now we will only focus on the umbilical artery. And this is used routinely in the assessment of high-risk pregnancies. Now let me introduce you to the UMBIFLOW studies. And before I explain this in more detail, I want to first acknowledge the large role that the South African Medical Research Council has played in supporting this work over many years, as well as the CSIR in the development and manufacture of the UMBIFLOW device. It is a proudly South African invention. UMBIFLOW uses continuous wave Doppler of the umbilical artery. It measures the systolic and the diastolic flow as seen on this picture, and it then works out the resistance index or the RI. As the pressure in the vascular system increases due to changes in the placenta, the diastolic flow decreases and this RI, the resistance index, increases. The diastolic flow can even become absent, showing pending placental failure, and in extreme cases can even reverse. This is like cycling a bicycle. Okay? With normal pressures, it is easy to paddle. It's like you're going downhill. But when the pressure increases in the system, this is like having to paddle on an even stretch. And later, you even need to paddle uphill. So in research, Ambiflow was used in primary healthcare clinics in low-risk women. It was used as a screening test done at between 28 and 34 weeks gestation in order to prevent stillbirths. It is a low-cost portable device which can be used by midwives during routine antenatal care after a short training course. And the system has an easy traffic-like system for interpretation of the results and thereby easy referral process. There were 3 pivotal Ambiflow studies done by the obstetric team at our research center, led by Prof. Pattinson. There was the initial Ambiflow study in Mamelodi, led by Dr. Spencer and Corsi, and then the Ambi-9 study in 9 sites throughout South Africa, and the Ambi International study in 5 low and middle income countries, including South Africa. So let me tell you some of the highlights. The Ambi-9 study, which was the PhD study of Dr. Tsakani Hlongwane, who's here tonight, recruited more than 7,000 low-risk pregnant women in 9 sites in 8 provinces throughout South Africa. It found Dopplers, abnormal Dopplers in 13% of women with absent end diastolic flow or impending placental failure in 1.2%. Again, to highlight, these were healthy women with presumed healthy pregnancies. We're not talking about high-risk pregnancies here. Summarizing the main findings from the study, the prevalence of the abnormal Dopplers was 10 times higher than what was previously reported from high-income countries for reasons that are unknown. And then, does the use of Doppler information prevent stillbirths in this low-risk population? And this was found to be a resounding yes, with a risk reduction of more than 40% in the population who was screened by Ambiflow. Therefore, Doppler of the umbilical artery can be used as a stillbirth prevention tool in our setting. Can it also be used as a functional test to detect fetal growth restriction? Our group was determined to find out. The Ambiflow International study was a WHO-sponsored prevalence study which was done in 5 countries, namely Ghana, Kenya, Rwanda, India, and South Africa, and led from our research center. The study was led by Dr. Valerie van Jevel and also recruited over 7,000 participants. The main learnings were that the prevalence of abnormal Dopplers was just under 7%, with the highest found in Ghana, while absent end diastolic flow was found in 0.2%, with the highest in South Africa. Furthermore, infants with abnormal Dopplers were found across all birth weight centiles. And thirdly, the cumulative percentage of birth weights was shifted left in the group with the abnormal Dopplers. Now, if you're trying to get your head around what this means, let me try and show you this in a different way. If one plots the birth weight Z-score distribution of a normal population of babies, this should follow a normal distribution curve, which is centered around 0. The blue curve here shows the babies in the Ambi International study, in the South African cohort, who had normal Dopplers. One can see that the normal distribution curve, which is just off-center, that is, there are some other factors that result our normal Doppler babies to be slightly smaller than expected. But this is not pronounced. The red curve, however, represents the babies with abnormal Dopplers, and one can appreciate that the expected birth weights are smaller than expected. What is, however, also evident here is that there are also bigger babies who have abnormal Dopplers. So a baby who was genetically destined to weigh 4 kilograms at birth, but now is born at 3 kilograms, will not be flagged routinely as growth restricted, despite severe underlying placental insufficiency. Thank you, Sam. So the stillbirth caused by placental insufficiency are therefore only the proverbial tip of the iceberg, or what we would rather want to explain as the ears of the hippo. With the fetal growth restriction, the much larger, unseen clinical concern. From the pediatric and nutrition perspective, we became more and more concerned about what these obstetric findings mean for childhood growth and development. We therefore recruited inference from the local South African UMBI international study for further follow-up. The UMBI baby study hypothesis was that the placental insufficiency, as was measured by the abnormal Dopplers between 28 and 34 weeks, reprogrammed the infant's pathways in terms of their growth and their development. You will appreciate that the study design is very similar to the Siakula study, which I have already shown you. This had many advantages also because we had now two different data sets with similar design from the same geographical area, assessing different factors that impact early childhood growth and development. In addition, we also added a cross-sectional study at age 18 months, which we called Ambigodisa, where we recruited a larger group of participants, and we were particularly interested to study the combined impact of placental insufficiency and in utero HIV exposure on early childhood growth and development. Actually, we thought maybe maternal HIV was a contributor to the placental insufficiency, but it was not to be that simple. A reminder on why clinical research is so important to do. As I'm sure you will appreciate that there are many research results from these studies, but I've put together 3 summary slides with the highlights. Firstly, the 18-month-old Ambigodisa participants for whom we had prenatal, perinatal, and postnatal information available, and we studied exposure variables that affect body size and body composition outcomes. So we found that at birth, the higher Ambiflow RI Z-score babies predicted a lower birth weight and birth weight Z-score. This was expected after the findings from our obstetric colleagues. At 18 months of age, the most pronounced findings were on length for age Z-score, with a higher Ambiflow, that is a more abnormal Ambiflow result, being significantly associated with the lower length for age. In summary, children with higher Ambiflow Dopplers had lower birth weights and lower length for age at 18 months. Secondly, I wanted to show you the trajectory analysis of the term babies from the UMBI baby cohort. This project was formed part of Sanya Nell's PhD, who graduated last week Friday. For each of the growth parameters, various growth trajectories were modeled, mostly in 3 groupings, which is a high and a middle and a low growth trajectory over time. In summary, the size of birth, which the birth weight Z-score, predicted the weight for age, weight for length, fat mass, and fat-free mass Z-scores. Okay, and remember I asked you at the beginning about your birth weight. Okay, can you now see how important these parameters actually are in further childhood growth? So the Ambiflow predicts the length for age and the fat-free mass Z-scores, with fat-free mass mostly being the muscle and the bone components. And we can see here on the graph, the lower graph there, how this trajectory actually decreased over time, which is really bad news. It means our children are growing and putting on fat, but their muscle and bone mass is actually decreasing over time. So routine Ambiflow screening in pregnancy was therefore able to identify infants at increased risk of later stunting. And then lastly, the results of the dual exposure in the Ambigodisa study, the research done by Motusi Nyofane for his PhD, who also graduated last week. So the dual exposure group, those were the babies who had in utero HIV exposure and also had an abnormal Ambiflow, had significantly lower weight for age Z-scores and head circumference for age Z-scores compared to the control group. And the significant effect on the length for age Z-score is seen on the graph. So just look at the red box there. Those are the babies who actually had both in utero exposures. The prevalence of stunting in that group, the dual exposure group, was 40%. and 16% in the HIV-exposed babies with the normal, who actually had a normal Doppler. We also examined the neurodevelopment, and we found cognitive delay in the dual exposure group, but this effect was driven by the abnormal Doppler group. So in summary, what did we learn so far from the AmbiFlow studies in terms of the umbilical artery Doppler and fetal growth restriction? So firstly, as the placenta is the sole source of nutrition for the fetus, placental insufficiency leads to fetal growth restriction, and in severe cases leads to stillbirths, as shown by our obstetric colleagues. The AmbiFlow studies then showed, in a nutshell, that children born to low-risk pregnancies who had an abnormal AmbiFlow have significantly lower birth weight, cumulatively birth weight distribution curve shifted to the left, have higher rates of small for gestational age and low birth weight, have lower length for age and fat-free mass Z-score trajectories over 2 years, have accentuated stunting risk if they have this dual insult, and have cognitive delays at 2 years. Therefore, the AmbiFlow Doppler is a useful tool for detecting the risk of stillbirths, fetal growth restriction, and later stunting, amongst others. The academic journal Lancet published a series on small and vulnerable newborns in the year 2023. It included calculations showing that globally 35 million babies were born with one of 3 vulnerabilities. Either born too soon, so preterm, born too small, therefore small for gestational age, or low birth weight, less than 2.5 kilograms. And these vulnerabilities account for more than half of all neonatal deaths. In Tshwane district, 13.4% of babies are born low birth weight, as per District Health Information System data from the year 2022. For the other 2 vulnerabilities, the preterm and the small for gestational age, we don't have good routine data. This brings us to the so what question. Why does all of this matter? So far too many children in low and middle income countries are not reaching their full genetic potential. And there are several drivers of risk which may be compounded. I have discussed mainly 2 risk factors tonight, namely placental insufficiency and HIV exposure, with the third very important risk factor being prematurity. Importantly, the discussion has highlighted these risk factors in women with otherwise low-risk pregnancy. Once one overlies additional risk in high-risk pregnancies, the compounding of risk factors becomes even more pronounced. One such major risk factor is, which is also associated with placental insufficiency, is hypertensive disease of pregnancy, which is also very common in our setting. And so while we don't disagree with the 3 vulnerabilities named in the Lancet series on small and vulnerable newborns, namely preterm, SGA, and low birth weight, this does not take into account whether or not a fetus actually had fetal growth restriction. We therefore propose that babies, in addition to being classified as term or preterm at the time of delivery, that the growth restriction as measured by the antenatal Doppler is also included, with preterm growth-restricted newborns likely at highest risk of suboptimal outcomes. In summary, let me describe the crucial next steps. In terms of improving clinical care provision, we need to have a strong focus on stillbirth prevention. Umbilical artery Doppler screening is proven to be a powerful tool to identify pregnancies at risk of stillbirth, and this needs to be rolled out in South African clinics as part of routine care. Additionally, we know that we have vulnerable mother-infant pairs who need care, especially in these first 1,000 days, and I will show you our thoughts on how to move this forward. Additionally, we need to tackle the unknowns by doing further research. This includes studying how to optimize technological advances during antenatal care. Furthermore, we need to study the overlapping risks of prematurity and placental insufficiency. And then there is the big question on everybody's mind. What is the cause of this placental insufficiency in our pregnant population? And as the current answer to this question is, we don't know, this means that this clearly needs to be a research priority, as this would be a potential game changer for us in terms of greatly improving perinatal and child outcomes in our setting. So Ambitswane, so taking those 4 points, so let me show you the projects that we are either busy with or currently embarking on. So Ambitswane is the first a rollout of AmbiFlow in routine health services, which is currently underway in Tshwane sub-districts 5, 6, and 7. And this includes both urban and rural areas. The main question of Ambitswane are what is required to effectively integrate AmbiFlow into routine antenatal care services? And then what is the impact thereof on perinatal outcomes? The results I've shown you was out of research projects. This is now moving it into the routine health services. This project is currently ongoing and we're learning many practical lessons and data collection is in process. Next, I want to tell you about the project called Sihamba Kunye, which aims at implementing a structured and integrated postnatal care package, a first 1,000-day roadmap for mother-infant pairs at the same service delivery point at primary healthcare level. This project is supported by the Gates Foundation. The South African Road Health book has already been in place for many years now, and it provides an excellent clinical roadmap for every baby. But it is currently in practice divorced from the healthcare that the mother actually, or the caregiver actually receives. This results in multiple uncoordinated visits for the two, which, if we were able to integrate this, will reduce the number of visits needed, for instance, for maternal family planning and HIV-related care, and the routine care needed by the baby, from 11 visits to 5 visits to the clinic in the first 6 months of life. So care packages for the mother and the baby are available. So the what should we be doing when the mother and the baby actually come to the clinic? This is available. But the who, so the how and the who, the how should we actually do this in the best way, and the who, the best staff member to do this, will benefit from streamlining. The questions are the following. How do we improve provision of health services and thereby health? How do we reorganize our staff, space, and flow within the primary healthcare clinics? Will the mother actually like this integrated care provision? Can it save us money? And is it something worth doing at scale in South Africa and other resource-limited settings? This project focuses on the provision of routine care as a foundation, but it would also make it possible then to add onto that the better care for the vulnerable child who is actually in need of extra care, which would include children who were born prematurely, with fetal growth restriction, who are exposed to HIV, or who have other social or medical risks. Next in line are the tandem projects that are called Siyakubona and Sibona Abantwana. Siyakubona is a Gates Foundation funded project with a donation of 500 butterfly point-of-care ultrasound devices to South Africa. And the Global Ultrasound Institute is the training partner on this project, while the Clinton Health Access Initiative is the implementation partner. We are, as UP, are the scientific partner on this project. The implementation is currently in progress in 6 provinces throughout the country. The objectives are to increase the proportion of South African pregnant women who have an antenatal ultrasound before 24 weeks, as per WHO recommendation, and thereby improving pregnancy outcomes. The benefits of this project include improving accurate dating of pregnancies, diagnosis of multiple pregnancies, abnormal placental location, and abnormal fetal lie, right at the level of the clinic where the midwife actually is doing the antenatal care. And furthermore, to understand how maternal and fetal outcomes, fetal referral pathways, and health system usage is affected if we actually have routine point-of-care ultrasound available at clinics. And then in selected geographical areas to also understand the potential synergistic effects of providing both the point-of-care ultrasound and the ambiflow during routine antenatal care, to see whether we can really bring that stillbirth rate down at scale in our country. The partner study is Sibona Abantwana, and this focuses on fetal growth restriction and child outcomes. And we are very grateful to the support of the Elma Philanthropies in this endeavor. This project will investigate the causes and consequences of placental insufficiency. As I've already alluded to, the etiology of this commonly occurring placental insufficiency is currently unknown. And we will investigate 3 possible pathways, namely dysregulated angiogenesis, inflammation, and maternal nutrition status. Furthermore, we want to look for possible clues on whether this placental insufficiency in otherwise healthy pregnancies falls within the preeclampsia spectrum, a condition that presents with severe placental disease. And then in terms of the consequences of placental insufficiency on the offspring, the focus of this study will be on the infants who are now additionally born preterm, additionally to the placental insufficiency. Dear audience, the year 2030 is very near, and we need to move with great speed on the Survive, Thrive, Transform agenda in order for us to reach our sustainable goals. Everything I've shown you tonight is grounded in teamwork by a fantastic group of people anchored at the Research Center for Maternal, Fetal, Newborn and Child Healthcare Strategies here at the University of Pretoria. I really want to acknowledge the founder and previous director, Prof. Bob Pattinson. And then there's a big special thank you to my colleague and friend, Dr. Helen Mulol, who's also here tonight. I think every student attached to the Research Center owes her boxes of chocolates, because she helps everyone with study designs, questionnaires, databases, data analysis, writing, and just being always there to lend a helping hand. And then to my group of PhD students, the 3 who just graduated this year, the current ones and the 4 who are currently in the pipeline, I know it is not easy. And then to my co-supervisors of the PhD students, it's such a pleasure working with all of you, everyone with their own style of supervision. And then there's a big group of other collaborators, master students, and I'm now definitely going to be in trouble because I'm sure I forgot somebody on this. So being clinicians and doing research is a challenging combination. But I think the summary of some of our work, which I have been able to share with you tonight on behalf of our team, really shows you clearly why we need to do this. We need to understand what is driving the mortality and morbidity in our setting. So I want to end off with a quote from this Lancet series of small vulnerable newborns. The fact that every 4th baby in the world is born too soon or born too small is a concern for human rights, public health, the national economy, and development. By not addressing this priority, we are jeopardizing our collective future. So, ladies and gentlemen, the first 1,000 days matter. I thank you.
Ladies and gentlemen, please allow me to thank Professor Ute Feucht for her insightful inaugural address. Let's give her another round of applause. She has highlighted the pivotal period of the first 1,000 days in unlocking each child's genetic potential and contributing towards their lifelong health. The most touching is that the South African subpopulation, suboptimal child growth and development are highly prevalent, and that the window to intervene, to change the trajectory of development of a child is mere 1,000 days. The research by Prof. Feucht contributes significantly to the range of interventions available to maximize our impact in the first 1,000 days, so that we can improve the lives of the child population and contribute to achieving the Sustainable Development Goals. Colleagues, let's continue to conduct research that matters and make a difference locally and globally. Finally, allow me to thank Professor Loretta Ferris for leading us in today's inaugural address, members of the University of Pretoria Executive for their continued support, Faculty Executive Committee at the Faculty of Health Sciences, and the team at Health Sciences, Samantha Hodgson and Karen Dupree for the arrangements, and Louis Kluter Production, thank you for making this event possible. Distinguished guests, staff, students, and audience, thank you for joining us this evening, online and in person. For those in attendance, please join us for refreshments. Stay safe and good night. Thank you.
Vivat Academia, vivat